Well, thank you for this nice introduction. And, if you look at this, up here it says, new rules, new values. And I'd like to start my talk with a very brief historical view of attitudes to female sexuality. Let's focus on, for a couple of seconds or minutes, on the 19th century. In the 19th century, it was thought that menstruation and sexuality have a very deleterious effect on intellect in women. And there were all those funny diseases like menstrual madness, nymphomania, masturbation, moral insanity, hysteria, and neurasthenia. And many of those diseases were thought to be the result of inappropriate reading or playing music. But it comes worse. Cause of all evil was considered to be the clitoris, or to be more precise, masturbation. This was perfectly okay for men. It wasn't for women. So the cure was either for menstrual madness, for example, we call it PMS today, removal of the ovaries, or removal of the clitoris. And I'm serious about this. There is a little book about this, published by Baker Brown in the 19th century. And in this book he says, clitoridectomy is a cure for all those diseases, for nymphomania, for masturbation, for hysteria, for epilepsy, catalepsy, for depression, insanity, dementia, you name it. And I'd like to give you 2 examples taken from this little book of the indications for those surgeries. This is my first example. A woman, middle-aged. There was evidence of peripheral excitement. I performed my usual operation and the patient made a good recovery. She remained quite well and became in every respect a good wife. So what was her disease? What was the indication for this operation? Her disease was her desire to obtain a divorce under the new Divorce Act. And the second one, picture a 20-year-old girl. She was disobedient to her mother's wishes, sent visiting cards to men she liked, and spent much time in serious reading. And I guess that there are many women in this room who would have been perfect candidates for this kind of operation. The issue here is Baker Brown was not alone. There were others. For example, Charcot, a very famous neurologist who taught at the well-known La Salpêtrière Hospital in Paris. And he also believed that mental disease in women results from abnormalities or excitation of the female external genitalia. And behind me, you see in a picture, in the midst, there is Charcot, and he's surrounded by his disciples. And then there is a woman having a hysterical attack. These clinical rounds were absolutely famous. And if you look at this picture, what do you see? All men. Medicine was male at this point in time. And just picture for just 1 minute what happened there. All these men discussing in every detail, or maybe even viewing in pornographic detail, the role of the clitoris and the vulva in the development of hysteric attacks. And it comes worse. Many of you might not be aware that Sigmund Freud, famous for psychoanalysis, attended those clinical rounds for 5 months. Okay, these are the really dark ages of sexual medicine. Many doctors are not aware of this, but I thought it would be very valuable for you to know about this. So what about modern sexual medicine? Today, we focus on how do things work. And actually, Masters and Johnson, 46 years ago, introduced the first sort of scientific model of female sexual function. They proposed a linear model of sexual function for men and women. And all of you know this. There's arousal, then there might be a plateau, then there's orgasm, and then there is resolution. And then, in 1979, Helen Singer Kaplan came along and said, oh, there's something missing. What about libido? What about desire? So desire came in. Desire came in at the beginning, the driving force behind sexual activity. And many of you in this room were brought up with this concept that sexual desire comes first, and then there is sex. But think about this. Is this the truth? Spontaneous sexual desire, does this exist in women? I'd like to challenge you for 1 second, the women in this room, maybe the men as well. So why do you have sex? Or why do you think women in general have sex? Women who claim that they're happy with their sexual life, not women saying, I'm absolutely unhappy with what's going on here. You're done with this? Okay. So science. What tells science you about this? It's about the desire to express love. It's about receiving and sharing physical pleasure. This is about feeling emotionally closer to your partner. This is about pleasing the partner, increase own well-being, and then there is this issue of self-image, feeling attractive, desired, loved, feminine, appreciated. And then the last issue, women do not like to talk about it, but this is real. I sit in my office day by day and I listen to those women, and this is what they say. Sex is used to reduce the feelings of anxiety or guilt about sexual infrequency. What about desire? Do you see desire on this list? It's not on this list. If you sum up, this is about emotional intimacy. This is not about sexual desire as a starting point for sexual activity. And this is the basis for the new model. It's also called the intimacy-based model by Rosemary Besson, saying that at the beginning, there is sexual neutrality, but with a positive motivation. And the result of this is a willingness to become receptive, to actively find a sexual stimulus and focus on this sexual stimulus if the situation is adequate and the sexual stimulus is adequate. This sexual stimulus is then processed within the brain with numerous factors influencing what's going to happen in the brain. But if things goes well, subjective sexual arousal occurs. If the sexual stimulation continues, the next step would be that the woman becomes excited, more and more and more excited. Sex is more and more pleasurable. And then out of a sudden, there is the desire for sex itself, which hasn't been present in the beginning, but is now present. So this is completely different from the Kaplan model with sexual desire in the beginning. Here, it's the sexual desire happening en passant. So if things go well, and if the woman stays focused, if the sexual stimulation is long enough and adequate, sexual satisfaction may occur with or without orgasm. So again, think about it. What was the reason to engage in sexual activity? This was about emotional intimacy. So it's absolutely important that there are two positive outcomes here. On one hand, on a physical basis, this is the aspect of sexual satisfaction, and on the emotional side of the story, to further increase motivation to have sex again. Spontaneous desire might be present in the beginning of a relationship. However, it of course smoothens the situation, but it's not present all the time. And if you think about this, well, there are many reasons why this doesn't work. Factors that might torpedo this sexual cycle. For example, if he's a poor lover, if he doesn't know what to do. Well, you can say this comes down to communication. But again, I mean, it could be an issue in some situations. And then there is this multitasking thing. Women say, I can do everything at once. Okay, we try to do this. If you try to do 2 things at once, well, you might notice that both processes slow down. And if you try to do 2 things at once concerning sex, it simply doesn't work. And again, on top of that, being busy all the time with our brain, women have the difficulty to focus on what's going on. You know, she might be engaged in a sexual activity, and out of a sudden she thinks, okay, it's hot in here, and the room needs to be painted. Okay. And picture what happens. It's all gone. She's lost. So what about pain, distress, anxiety? If he suffers from erectile dysfunction, forget about this. It's not going to work. Okay, I've lost interest in sex. Let's have a look at the neurobiological perspective here. let me digress for a second. A short excursus and on brake and gas. So if you want to drive a car, you need to do two things. Number one, you need to release the brake. Number two, you need to accelerate. Otherwise, things don't work. If you try to do both things at once, you'll notice this doesn't work, okay? Okay, what does this have to do with sex? A lot. Okay, all behavior, including sexual activity, is influenced by two major factors. On one side, factors that inhibit a specific behavior, and on the other side are factors that support or excite a specific behavior. This also applies to sexual activity. It's called the dual control model. Okay? Now, if we focus on sex, there are two things. There is inhibition on one side, and on the other side, there is excitation, triggers that cause arousal and desire. But those two need to be balanced. So if you want to engage in sexual activity, you need to be able, on one hand, to decrease inhibition. We usually walk around in the inhibited mode, which is something which is actually pretty smart. Picture what would happen otherwise. Societies wouldn't work, right? So, but on the other hand, you need some trigger at least, because spontaneous desire is rare. It might happen under certain circumstances. I'm going to talk about this in a minute. But usually it's not there, so we need a trigger. So you might say, wow, that's complicated. Surprising that it works at all. I agree. And I'd like to show you, you have already seen pictures like this, functional MRI data published a couple of years ago, but really interesting data. So what was done here is basically a research setting where a woman was stimulated, clitoral stimulation, and then it was measured what happens in her brain. So on the upper row, you see arousal, and on the lower row, you see what happens during orgasm. So you see blue and red dots. What is this? Red is an increase in perfusion, and blue is a decrease in perfusion. And there are lots of blue dots on the lower row. This is orgasm. And those dots are in a very critical area of your brain, frontal lobe. So you need to know, what is this good for? This is good for control. This is very basic, I have to agree, but basically, in essence, this is what the frontal lobe is good for. So if you want to experience an orgasm, you need to be able to give up control. That's what it's all about. But the issue is, this sounds so simple. It's not. It's not at all. If you can't focus on a sexual activity, or if you are, for example, distressed like hell, if you are anxious, if you are depressed, this does not work. There is no way to get aroused or to have an orgasm. It just doesn't work. Men are a little better off here compared to women, but women really do have difficulties. So it doesn't come as a surprise that research has focused on what are the neurotransmitters involved here, and so what is on the gas side and what's on the inhibitory side. And if we look at this on the gas side, there are neurotransmitters like dopamine, noradrenaline, oxytocin. Oxytocin has to do something with binding. Dopamine has something to do with the reward system. And the melanocorticoids that have something to do with appetite and sex. Eating, basically. So on the brake side, we have others. We have 5-hydroxytryptophan, we have the opioids, and we have the endocannabinoids. So you might have heard 5-hydroxytryptophan. It's metabolized to serotonin. So serotonin, does this ring a bell? If you're depressed, the doctor might put you on an SSRI, that's a serotonin reuptake inhibitor. So if you're on this drug, it might be great for depression, but it's the brake for sexual activity. Okay? So if you're depressed, you're really in trouble. There's one situation where you are sort of, you suffer from neurosteroid intoxication, but most of us like this state. So what happens here is your brain is flooded with those wonderful neurosteroids that make sex easy. Dopamine, noradrenaline, apparently, at least some studies suggest this, there is a decrease in men of testosterone, and in women there is an increase, but there are not that many data to support this. And then after 6 months, well, what happens? After everything goes back to normal. This is the moment where you suddenly think, okay, he's not that smart, is he? And he doesn't talk to me. So, I mean, this is the moment where you put off your glasses, yeah? No pink glasses anymore. So this is what this is all about. And there is this little difference. I'd like to do this briefly because I'm running over time otherwise. Men and women are not alike, and we all know this. So the issue is, what happens? The hypothesis is a sexual stimulus is really going fast through a man's brain. This is called the quick and dirty pathway. With women, the situation is a lot more difficult. This is the neat and slow pathway, okay? It sounds funny, it's not, if you think about it. It's androgen dependent and context dependent. Well, that's smart, you know, given the imbalanced investment here. What does he invest? You know, we heard about this risk-taking thing this morning and being testosterone-driven, a sperm. What is her investment? A pregnancy. So it's actually pretty smart to think about this twice, right? But if you're in a longer-running relationship, then you are getting in trouble. Okay? I discussed this concept with a friend some time ago. We both sat in an airport lounge, and I sat there and tried to explain this concept of differences between men and women. It's always funny. Okay, and then I looked at this plane, the jumbo, about to take off, and I thought, well, that's it. This is how female sexuality works. Before this plane leaves up, there are those checklists. And if there is one red light, the plane is not going to take off. And then, you know, my friend said, okay, a male. He said, I got you. So men are like bicycles, just hop on and get off. Okay, you can put it this way. So you think you're in control? Well, we have learned a lot this morning about testosterone. No, you're not in control. Biology is in the driver's seat, and hormones are in the driver's seat. If you're a woman, you're at the mercy of your hormones. And the problem is, those hormones fluctuate throughout your cycle. In the second half of your cycle, your brain doesn't do what you want it to do. You know, things are getting slower at the around menstruation. You might feel miserable. Best time is shortly before ovulation. You know, women just feel fantastic. Day 11 till day 14, superb. Okay? And if it comes to sex, this is the situation when we are prone to have sex. Actually, we even wear tighter dresses, okay? It's visible. You think it's not visible? It is visible. Men can see this, if they are trained at least. And if women view an erotic video, they respond differently concerning brain scans, depending on which part of the cycle they are in. So you are not in control. Biology is driving the whole show. I mean, you are not. If you think you are, forget about this. Are there pills to boost sexual desire? Women come in my office and say, okay, I've lost interest in sex. Is there anything that I can do about this? And well, there are. What about hormones? In 1966, this book was published. And on the cover it said, now almost every woman, regardless of age, can safely live a full sex life for her entire life. Well, this was the beginning of the hormonal replacement therapy story. By now we know, well, things are by far not that simple. It doesn't work like this, but there are androgens. We've heard so many interesting things this morning in this brilliant talk about testosterone. Well, women do have testosterone as well, and it's important for women, absolutely. And by now, it's widely accepted that women who suffer from androgen deficiency have numerous symptoms concerning their sex life, but also concerning vitality, depressive symptoms, etc., etc., etc. And the wonderful thing is, testosterone works. Testosterone improves sexual function, desire, orgasm, responsiveness to sexual stimuli. It also improves vitality. It improves depressive symptoms. It does all sorts of things. And this is not surprising given the fact that testosterone interacts with numerous neurosteroids that are involved in the development of depression, in the development of low sexual desire. So testosterone does work, and it's available for women. So what does it do? Is this glass half empty or half full? That's the story. okay? And testosterone may shift you from half empty to half full, okay? Anything else? What about drugs affecting the central nervous system? And you have seen this picture already. I'd like to call those drugs balance modulators. It's a question of where are we? Are we on the brake side or are we on the gas side? And are we able to shift from the brake side to the gas side? And there are a couple of drugs under development. One almost made it to the market, flibanserin, last year, but the FDA said, no, we need more research. It worked actually pretty well. There are other drugs out there who do the job. So the question is sex tuning the future? Well, difficult question. And there are people out there who say this is just merging of marketing and medical science. And they claim that this is a making of a disease, female sexual dysfunction. Please don't get me wrong. I'm not here to say that low sexual desire is a disease. Not at all. If you're comfortable with your level of desire, perfect. This is what I'd like to see. But if you come to my office and say, I have lost interest in sex and I suffer like hell, I don't have any idea what's going on here. And this is about 10% of the women across all age groups. Well, maybe she would be a good candidate for a medication like this. She would like to have the chance to choose. And who am I to say, no, you don't get it, if it's available? But, you know, if you think about it, I've lost interest in sex. If we talk about this, it's always a question of, okay, who is suffering? Are you or is your partner? And then there is this issue of, I have lost interest in sex in relation to what? In relation to my own expectations, in relation to what I experienced in earlier times with other lovers, in relation to my husband's expectations or partner's expectations, in relation to society's expectations or what I think are society's expectations driven by the media. So you have to be quite clear on what does she really mean if she says she has lost interest in sex. And in the end, in many cases, it's not about drugs. It's about communication. And this is one of the reasons why all of us are here. Communication. Thank you.
Thank you very much. Thank you very much. Anneliese, that was wonderful. And of course, if you check your goodie bag, the DLD goodie bag, we have, of course, a sample with some testosterone in there. So enjoy, and please send us your feedback. No, I'm just joking. Yes, now we're having the third very wonderful expert who is going, we've been talking quite a lot today about it, about in social media, how